We'll be live in a few seconds.
Akhil, we are live, I guess.
Yeah. Good evening and a warm welcome to Expert Talk series. My name is Akhil Rashid and I am the Research and Knowledge Hub Chief at Jammu Kashmir Policy Institute. I'll be starting today's session and introducing the speakers. Jammu and Kashmir Policy Institute has initiated the Expert Talk series to engage experts, changemakers, pioneers from various walks of life to understand the dynamic context of implementing the UN Sustainable Development Goals on our agenda. The vision and intention of the Expert Talk series is to source inputs, recommendations from experts in various fields pertaining to different sustainable development goals through one-on-one dialogues. The hour-long interactive session will consist of one-to-one dialogue between the moderator and the experts to dig deeper into various topics and probe their various dimensions with a dedicated Q&A. The entire session is being broadcasted live on the official Facebook page of Jkpi. Today, we are delighted to be joined by Dr. Shafqat Khan and Dr. Chandrakant, who have a distinguished career in public policy and the health sector. They will be talking to us on the topic India's healthcare and vaccination policy, and they will be analyzing the preparedness and scope of improvement for the same. Let me begin by introducing Dr. Shafqat Khan, who is the officer on special duty to the Additional Chief Secretary, Health and Medical Education Department of Jammu and Kashmir. He has graduated in medicine with masters in health management and worked in key positions in various leading capacities in the state government, including CEO, Health Infra Projects, Municipal Commissioner Srinagar Municipal Corporation, and Joint Commissioner Special Cell for Migrants at JK House, New Delhi. He has also prepared the Smart City project for Srinagar City and got it approved by the Ministry of Urban Development, Government of India. Dr. Khan specialized e-governance and digital transformation in government and implemented single window system for issuance of births and deaths certificates and building permissions. He specialized and implemented solid waste management systems. We also have with us Dr. Chandrakant Leharia, who is a medical doctor and India's one of the leading public policy vaccines and health systems expert. He has worked with academic institutions and as well as 13 years of prior experience with the World Health Organization. He's a leading Indian expert in vaccines and vaccination programs, health systems, strengthening and the universal health coverage. In the field of disease outbreaks, epidemic, and pandemics, his work is a synergetic mix of academic research, public policy formulation, and field implementation. He is among us the leading Indian expert in the COVID-19 pandemic preparedness and response. His scientific article has published in reputed national and international medical journals. He writes regular columns for leading English and Hindi newspapers. He's also the lead co-author of book Till We Win, India's Fight Against the COVID-19 Pandemic. Dr. Chandrakant is the recipient of Dr. B.C. Srivastava Foundation Award of the Indian Council of Medical Research for his work on translating community-based health research into public policy. He is the youngest fellow ever elected in the history of prestigious Indian Public Health Association. On behalf of the entire team of Jkpi, I welcome you both. Thank you very much for taking the time to be with us. Now, without much further ado, I would like to pass on the mantle to Ms. Jigyasa, our facilitator for the evening. Thank you.
Thank you so much, Akhil. And once again, a very warm welcome to both of our speakers. And I would like to just begin with a very general question, I guess, and that is regarding the healthcare system itself. So when there was an outbreak of the pandemic, it was very much evident that India's healthcare system and the entire infrastructure was not prepared. But it has been more than an year so far, and there has been many changes that India has actually adopted itself. But still we see a lot of lag. For example, the vaccination itself is not available to everyone, and we still face, for example, what recently happened in Delhi, the oxygen supply. So the infrastructure still suffers. So I would like to ask our speakers, what do you think, based on your experience and expertise, is the current state of health infrastructure to manage the current as well as the future health crisis? And I would like to start with Dr. Leheria. If you can give us a general overview of where India's healthcare infrastructure stands right now.
Thanks, Jigyasa. So the first point we need to remember that we have to prepare any health system well in advance for epidemics and pandemics. No country or no setup can immediately respond and prepare for a pandemic when it has happened or it occurs in that setting. So that is a challenge. Before the pandemic, we need to remember, and when we examine any health system, how well it is performing, we should always see from the outcome perspective. And if we look from outcome perspective, health status of population, health outcomes in India, well before pandemic, which started, which was declared in March 2020, we know that there was a wide variations in health outcomes. Let's take a basic example of common indicators such as infant mortality rate. The number of infants who die per 1,000 new birth. And this vary in Indian states from around 9, 10 per 1,000 of infant mortality rate to around 47 to 50. So there was a wide variation in health outcomes in infant mortality rate. Similarly, true for maternal mortality ratio. It varies from around 60 in Kerala to around 300 in Uttar Pradesh and Bihar. So there has been a wide variation, and these indicators are reflections of poorly performing health system. That's one part. Second part is that we also need to remember that, and it is widely recognized, government recognize this, that the government spending on health in India has remained low. It is one of the lowest in the world, in the bottom 20% of the country. Indian government spend around 1.15% of gross domestic product on health. And it has proposed now to increase to 2.5% of GDP. But if we compare with other low and middle income countries, 4 to 5% of GDP they spend. The OECD country, European countries spend around 8 to 10% of GDP. So spending on health services and health outcome have always remained poor. Having said that, also all the countries should prepare for such eventualities, and that is something called surge capacity, which essentially means you prepare for such eventuality when there is a disease outbreak. But there were all the challenges. Having said that, we should also recognize that Indian government started responding at various levels to the pandemic. A number of things happened which were really important and good, that it stepped up capacity for testing across the country. So COVID-19 testing increased across the country. The personal protective equipment which were not being made in the country were easily available. Of course, hospital beds which were existing were repurposed for COVID-19. But we also need to remember that it worked up to a particular level. When in the first wave, India has around 100,000 daily cases, it worked well. But in the second wave, when number of cases gone up, we know all the challenges which were faced. So it was not enough. And this reminds us to the old adage that we need to prepare for such eventuality. You cannot fight or you cannot respond immediately. You can do some work, So the best way to be prepared for epidemics and pandemic is to work when there is no such a situation. And final part is, I would strongly believe and would like to urge to any policymaker that we should derive lessons and learnings from ongoing pandemic, and those should be utilized to strengthen India's health system.
Thank you so much, Dr. Lahiri, and you have definitely bring in a very important perspective, that is the low allocation of budget that we are facing. It has negatively impacted the entire healthcare infrastructure, and then the very important point regarding the outcome perspective that we should be adopting. So with these points, I would like to turn to Dr. Shafakat. Uh, Sir, you are working on ground, I would say. I would like to ask you, what is the current state of health infrastructure, specifically in Jammu and Kashmir? Since you are working there, you have a very, I would say, a direct experience of working what is happening on ground. So I would like to ask you, what is the situation in Jammu and Kashmir? I'm sorry, sir, you're muted.
I'll begin with the same comments what Dr. Lahria said. And these are very important points. When you say that the health indicators of a community, of a nation, tell you about the overall health of the nation. So if you consider the infant mortality rate of the country, it is still much higher than what we want to achieve in the SDGs by the year 2030. But since you have asked me to be very specific about J&K, so I will tell you that our indicators have been very much better than the national average. And there have been commendable results coming in from infant mortality rate to maternal mortality and the TFR. I will tell you quickly that our under 5 mortality is 18.5, our infant mortality is 16.3, our neonatal mortality is 9.8 only, and our TFR, total fertility rate, is 1.4, which is much better than many other states. Then the other question was about the total financing of health systems. How much finance do we do towards our health system? So as earlier mentioned, that our total GDP, out of the total GDP, we spend on reasonable amounts we used to spend. And suddenly came COVID, so it was almost firefighting in the beginning, because of a novel disease, it was new, and no governments across the globe knew. There were governments which just crumpled under the huge pressure of COVID. So, and India was not different. We also faced the pandemic in the same way. And as far as our response is concerned, I understand that as a state, as a country, we did a lot better than many other countries in the South Pacific region. And India, if you say infrastructure-wise, we were lacking oxygen-supported beds. It was a very huge problem. And we had not anticipated that we'd need so much of oxygen. J&K in the beginning was lagging behind in this sector, but soon we had funding coming from the PM Cares Fund and the World Bank also. And we were able to take oxygen today. Our Honorable LG was telling us in the recent meeting that we should, in normal times, find out the use of this excess oxygen we have now in the state, and we should try to maybe put it to use in some other purposes when we don't need it. Same goes with the number of beds. We had deficiency of beds in the beginning, but we were lucky to have converted our hospitals at various levels into COVID dedicated hospitals, and we increased our beds. And then finally, DRDO came to our rescue also. So DRDO set up two 500-bedded hospitals, one in Srinagar, one in Jammu. And those 1,000 beds, came as a lot of relief. And these hospitals were, established in 2 weeks' time. I mean, it was a phenomenal, increase in beds in J&K. And suddenly, today we are seeing that the positivity rate in J&K is much less than 0.5 in most of the districts. And we have normal routine work going on. But nevertheless, we, as Dr. Laharia said, that we need to strengthen our systems to a level that we should be always able to anticipate pandemics, any catastrophe which is either natural or man-made, and develop robust health systems, which in fact is in consonance with what the SDGs tell us. We will have to fight communicable diseases. We'll have to fight the non-communicable diseases. We'll have to see how much we can reduce mortality due to drug and alcohol abuse. Drug and alcohol abuse is a new problem our society is facing. We have to reduce the number of road accidents and injuries. So talking of a holistic system would mean a smart hospital system in place. And when we talk about a smart hospital system, it will require a lot of digital interventions. It will require a lot of interfaces where we will have to rely on telemedicine. We'll have to rely on different variety of appliances which are digitally based. We are very lucky. We are very lucky in J&K. Had first the launch of Ayushman Bharat, where only the particular area of people was involved. But then Government of India was very kind to allow universal health care in J&K, where all the citizens of J&K were entitled to a 5 lakh, cover for each family, irrespective of the number of family, irrespective of the size of the family. And that way, our most important aspect, which is the health insurance part, that's the achieving of universal health care, was achieved in J&K. Today, you'll see half of our population is covered by universal health care. The numbers are steadily going up every day. But I think ensuring people, in our strata where our per capita income is so low, and we have very minimal reserves of people who have, reserves of money for illness. We go bankrupt. We become very poor immediately when disease, comes. We borrow money and, go to hospitals. So I think having a robust universal health insurance plan for all sectors in the states and the UTs of India, which will maybe be coincide either with the universal health program which the Union Health Ministry is introducing, or maybe the states are doing. But nevertheless, we will require that people should not suddenly fall ill and incur a lot of expenses on hospital care. So I think summing it up with all what I said, we will have to immediately start, working on solutions. One more solution is the, aspects of the intellectual property rights. You were asking in the beginning why vaccine was not available. So there were lots of issues about intellectual property rights, about who will manufacture the vaccine, the rights to manufacture vaccine, which are now being sorted out, of course. And vaccine is much more available across the globe, not only in our country, but elsewhere. I think the public health experts of this country will have to sit down and chalk out a longer, not only for COVID, but for any other eventuality, any public health, calamity which may strike anytime in the world, which is either natural or man-made. I think with that, I close the initial remarks.
Yeah, thank you so much, sir. And thank you for giving us a very, I would say, realistic picture of what is actually happening in JNK. And then I guess my second question would have been, what would be the recommendation that you would like to suggest? And you have, I guess, covered that part as well, having a very holistic approach where we are having a universal health healthcare plan itself, and the entire issues of IPR and how you can have a more broader approach of strengthening system itself. So with these,
So it is. I'm sorry. It's in fact embedded in the SDGs that you should have the early warning systems. You should have the risk reduction and management of national and global health risks. You got to evaluate them. You have to put down. I went to a training program 10 years back, which was organized by CDC and the American Embassy in Delhi. And there was 7 days being trained in infection control at a hotel in Delhi. And we had specialists from all over the country. So we anticipate sometimes, yes, these programs, these conferences, trainings to, train people about infection control and beyond, works a long way in, training and getting people to anticipate, risks and reduce those risks immediately.
definitely, sir. And I guess your point directly fits with the entire approach of our Expert Talk series when we are trying to look at how the pandemic has impacted the SDG itself and where we are actually lacking right now in terms of achieving it as per the time limit 2030. With this remark, I would like to again shift to Dr. Laharia, and I would like to understand the vaccination policy that India currently has and what are the loopholes. So my question would be like, what do you think are the major challenges right now that India is facing in terms of the effective rollout of the vaccination policy?
So we know that there are some struggle in India's vaccination drive rollout. It is not at the pace which we expected or which is needed to achieve the targeted vaccination coverage of all adult population. Alongside, and I think there are a few policy lessons from the challenges which we have faced in the vaccination drive till now. That we need to remember that India has always been a vaccine researcher. There for more than 100 years, country has research and development capacity in vaccines. That's one. Second, India produced vaccines which were exported or are exported to different parts of the world, low and middle income countries. Nearly 70% of the world receive vaccines from India. Third, India has some of the largest vaccine manufacturers in the world. So with all of these, even then countries is struggling for rolling out vaccination drive, and that is really telling. So the challenges which have remained there that we need to remember that any public health program or any intervention is not merely policy formulation. It is a close, especially vaccination programs are closely knitted interlinkage of policy formulation, assuring supplies and delivery. So if we recall that India definitely started very well and early on in one of the COVID-19 vaccine research and development, then there were policy groups which were contemplating or exploring that which population group should be prioritized. So there was a lot of attention for a few months on prioritization of various groups. And they said, oh, well, health workers will be prioritized, high-risk population, frontline workers. So a lot of attention was given on those policy aspects. But now wisdom of hindsight tell us that probably enough attention was not given to secure supply, because India placed first order on 11th of January, just 5 days before it rolled out vaccination drive. And of course, once vaccination drive was rolled out on 16 January, the people were not excited. The people, health workers who were supposed to get vaccinated were not very forthcoming, and there was hesitancy. So there were delivery related challenges. Now, it is a role of government, public health experts, and everybody who works in the program that we foresee all of those challenges which are likely to come in the program. And somewhere these are the learning that the vaccine hesitancy was not foreseen, the supply was not assured. And then though there was a lot of attention on vaccination drive, on identifying priority group, And somewhere in April, on 9th April, senior officials in the government said that vaccination drive is not for everyone, but it is only for a priority groups. And 10 days later, the vaccination drive was opened for entire adult population. Essentially, there was limited shortage of vaccine for the targeted population, but the vaccination target population was further increased by threefold, and all of those challenges emerged. So key learning here are that we, whenever designing any health program or any program which is linked to service delivery on any field to public, we need to focus upon more on assuring supply, assuring that delivery of that intervention than policy only, and then of course delivery. So there are a few good learnings from it. Now we also need to remember that though there are less supply than demand for the vaccine, but vaccines are a biological product. They cannot be produced overnight. Like if somebody assume that it will be like entire country can be vaccinated in a month or two, that is not going to happen. The vaccines are a finite supply. They would come in due course, but it's important that we know what is going to happen. We plan it well and implement it well, and that's what the key learning is. Coming here, I think now program is a little bit stabilizing. The vaccine supply will improve in the time ahead, and by end of this year, there would a reasonable proportion of adult population will be vaccinated. But again, here one of the challenges which we are missing and which should be given attention. For example, once vaccination coverage reach to 50 to 60% of target population of adults, there could be vaccine hesitancy which can sink in or which can reflect, and then coverage might not go on up. So government, policymakers, technical experts should plan for 3 months ahead when such situation may arise, and that will help India to fight COVID-19 pandemic. But the key thing is that we also need to remember that vaccines are a really important tool which will take country and the world out of the COVID-19 pandemic.
Thank you so much, Dr. Laharia, and thank you for actually bringing in a lot of different perspectives in terms of the challenges. For example, when you mentioned about assuring good supply, because definitely we have a finite supply of it, and then starting from better planning, then to implementation, and then foreseeing what could be another challenge, that is vaccination hesitancy. So with these remarks, I would like to again turn back to our next speaker. So what do you think are the major challenges in terms of the rollout of the vaccination policy? And again, I would like to ask you to give us some more in-depth view of what is happening in Jammu and Kashmir right now.
No, as rightly said, we could not prioritize as to who we needed to vaccinate at the beginning, and there were, some statements coming out from different variety of people, from public health experts, and then the vaccine hesitancy set in, like the other parts of the country. J&K also, suddenly nobody was coming forth, to vaccinate at all. Even healthcare, people had to be vaccinated sometimes by, persuasion and, explanations and all. But nevertheless, then it picked up, and now we in J&K, 45 above people, 100% vaccination has taken place. Only one district is left. And same is the case with the plus 18 vaccination. But I think we will have to, as Dr. Chandrakant said, that India is one of the biggest producer of vaccines in the world. We have been producing vaccines for over 100 years now, and we have been supplying them across the globe. And then maybe either we, took a little more time to start rolling out the vaccine, or we were hesitant as to, or there were some technical glitches in the beginning, wherever. So, but eventually, I think we'll have to still persuade lots of groups of people, which I see particularly in J&K. We have a lot of tribal population. We have a lot of religious, stereotyping, different kinds of groups of people who have to be persuaded to take the vaccine. We had to get together, religious heads, scholars, at the district levels, and all the collectors of all districts were doing such a marvelous job every day, every week. They used to have, these meetings with the religious scholars and the heads of mosques and every place. And ultimately, we are very lucky that a spontaneous response took place from the part of the society, from all sectors of the society, because we have tribals, we have different socially backward class people, we have difficult to reach areas. And you must have heard the story where one of our villages was 100% vaccinated. Our health workers had to go 20 kilometers on foot in the jungles, and a population of 600 approximately got entirely vaccinated, the entire village. And they were forthcoming, to vaccinate. Not that they didn't want to get vaccinated. So there are success stories in J&K, which no other state, union territory has done. And we are proud that we have, under the leadership of our LG, our chief secretary, our health secretary, everybody, and especially the deputy commissioners of all districts, everybody was very robust. And our LG sir used to have a meeting every alternate day, video conferencing with the districts, and how he used to give targets to them, 2 days, 3 days. And I think it has come very nicely, and we can be proud right now that J&K has done extremely good in terms of containment first, and then, the number of deaths, minimizing the number of deaths, keeping the infection positivity rate very low, and finally the vaccination part, which, as I already said, is 100% covered now above the age group of 45 plus, and the other age group is almost through. We have crossed 50%, and soon we arrive at 100% in that as well. Yeah.
Thank you so much, sir, for letting us know what is actually happening. Specifically, I guess one of the things that we usually miss is about a certain group, for example, hard to reach population, and specifically tribal, and the role of religious leaders in terms of both the positive as well as the negative impact that they can have in terms of the share of information, as well as impacting the opinion of most of the masses. And I could definitely observe some common points that are coming out right now, for example, in terms of the supply and what are the level of hesitancy among the individuals. So as both of you have already mentioned about prioritization of certain groups, so I would like to ask you, what do you think is the vaccine equity in terms of reaching different population, for example, specifically the marginalized groups like you say tribal that sir has already mentioned. So what do you think is the current level of vaccine equity that India has? So I would like to start with Dr. Lahiriya itself.
So vaccine equity is a really major challenge, both at international level and in India also. In India, we know that the majority of vaccination centers are in urban setup and less number in rural setup. And with the limited data available from Government of India, we know that more number of population people in urban setup, while the urban population in India is 1/3 of the total population, but more people in urban areas have been vaccinated than the rural population. But we also know that there is a little bit of hesitancy, though it may vary. Example of Jammu and Kashmir is different, that everybody is vaccinated, but in the states where vaccination coverage is low, majority of urban population is the one who is more forthcoming, and rural population is not, either does not have access to vaccine that easily or is not forthcoming, so that there is inequity in vaccination coverage in rural urban. But also we need to remember that one of the approach policy which Government of India has followed, that 1/4 of the total vaccine will be delivered through private sector, and then people can pay for that vaccine, which essentially makes a vaccine more accessible to rich population, or rich 20% of the population. And we also know that there is no shortage of vaccine in the private sector facilities, but there is a shortage. Many of the public sector or government healthcare facility or vaccination center need to be closed. So there is an inequity by affordability in the vaccine coverage. Third part is that Of course, there is a minor difference in proportion of women who are getting vaccinated, and then the men. We also know that, and there are limited studies, but this is true not only for COVID-19 vaccination, but other vaccination also, that there are inequities between the states also. There are states which traditionally for childhood vaccination have a low coverage. They would continue to have low coverage for COVID-19 vaccination unless something is specifically done. So the challenges in inequity by educational status or socioeconomic status are widely known. Unfortunately, we don't have that kind of data, granular data available in public domain. Public domain have a data on a limited parameters. But if we look at inequities, it's also by the districts and between the states, within a state, between the districts. So there are multiple challenges. Key thing from policymakers' perspective or health program managers' perspective is that we recognize that these are the likely challenges. For example, vaccine hesitancy can result in inequity once there is sufficient vaccine supply. So we need to identify which population group has a more hesitant toward the vaccine. There was one study which was conducted in Delhi, especially in urban slums, so 14 pockets of urban slum in Delhi and National Capital Region area. And what they found, that only 7% of the people in urban slums were willing to get vaccinated. Rest were not refusing, but they had opinions such as if we face such a challenging pandemic till now, probably we will overcome the challenges in the future also. They said we are healthy, we don't need vaccine. So there are challenges which are related to vaccine hesitancy, which indirectly will contribute to vaccine inequity or difficulty in achieving vaccine equity. So we need to identify all of those challenges, but this is there. Final part is that any pandemic and any improvement in outcome, it requires really good granular data from the government. And this is a responsibility of both national government, but state governments. And since we are talking in context of Jammu and Kashmir also alongside, it could be a good idea that the state of Jammu and Kashmir come up with a more granular data, share that kind of data, and that can set an example for the rest of the country also, that this is how we are measuring vaccine inequity or vaccine equity, and this is what can be done to tackle those challenges. So there is always hope and there are always solutions.
Thank you so much, sir. And definitely, there are major challenges, whether in terms of affordability and accessibility, and the major differences between the urban as well as the rural area. And I guess one of the significant part that we have mentioned is regarding the data, because most of the time when policymakers, like as we as a policy institute, we are trying to understand different aspects, we usually like that appropriate data and not even like the proper methodology that is available to collect that data. With these remarks, I would like to turn to Dr. Shafqat Khan again. So what do you think are the concerns in terms of the vaccination equity? And
Yeah, I will fully agree with Dr. Chandrakant that vaccine equity is a huge problem here, varied groups. But where I wanted to add that we had, an average Indian is always, comorbid. We have different kinds of diseases, which, a person, either he has congenital or non-communicable disease or communicable disease, or he has undergone some kind of surgery. He has visited a hospital, in his life he has visited a hospital a number of times. That is true for all, people. But in India, we have this thing that comorbidities were a problem. I'm telling state specific, that apprehensive. First, there was this group of women, who said, is it good for, pregnant women? So you had to really put on a lot of IEC to the masses, explaining that, women were safe, pregnant women. Then there was these patients who had undergone either angioplasty or some cardiac, surgeries or anything. They were also apprehensive. No, it will, affect my heart. Then another, person with a liver dysfunction or something. So there are variety of, informational aspects where you have to create equity among those who are comorbid, especially in a vaccine which is new, which is first time, where information is very limited. And I think that it took a lot of effort, and I'm talking about J&K. We had, Doordarshan, other TV channels. We had one slot, 1 hour morning slot in the morning on the television, and the evening slot 1 hour. And different doctors, ranging from endocrinologists, orthopedicians, ophthalmologists, and other, community medicine. Every type of specialist was available on TV, and they used to, flood people with information about the safety and the things attributed. So when it talks about equity, I think the foremost equity is the healthcare workers in all wars. First, the soldier needs to be, vaccinated, and then you go down wherever you need to, find out people which are either, sensitive to information, or there are stereotypes. Religion plays a lot of huge role in our country. People are especially the religious zealots, they try to put people into bad shapes and places when it comes to medical research and science. So I think we need to, take care of variety of complications in our country on the basis of religion, on basis of creed, caste, area where they come from, remote people, tribal people, people who belong to the hilly areas. So I think it was a good move by the state government, the UT government of J&K, by flooding people with huge and lot of information. Every doctor, every Maulvi of a masjid who was vaccinated would go on TV. We propose that the mullah or the Maulvi who goes for sermons in the masjid should go and tell people, yes, it is all right to have this vaccine. I have had this vaccine, and this is my certificate. So I think we achieved a lot of success in creating this information platform, which is very important. I think I don't blame people this time for not taking the vaccine. There were apprehensions. Very well-learned people, very educated people spoke to me about not taking the vaccine. They did not want to have this vaccine at all. But then gradually, when all kinds of people, different categories, health personnel, and everybody was taking, and they were safe, then everyone else came forward and had the vaccine. Yeah, that's it.
Thank you so much, sir. And it's really good to hear like what specifically, and I would say different approach was adopted by J&D government in terms of actually including religious leaders itself, in terms of disseminating information, and then the entire point of disseminating the right information is, I guess, something that we should cover, but I'm again afraid of the time because we have just like 17 minutes left with us. So I have to move right now to the Q&A session itself, and I'll be taking up question that we have already received. And I guess one question is directly related to what sir has just mentioned is coming, and it says that, so what do you think, what are the basic local government driven strategies that could be adopted to increase the uptake of vaccines? So I would like to ask both the speakers, but I think I can start with Dr. Shafaq sir, because you have just mentioned about some really different strategy that has been adopted in J&K.
You are dealing with. I mean, J&K is a varied, cross section of people living. It's a hilly terrain mostly, Then we have different religions. We have different set of people on religious basis. Then we have what kind of topographical terrain you are living in. Then the religious stereotypes. If you are fixed into some kinds of stereotypes where you need to challenge through different interventions. So what UT of J&K did was to target a particular group of people from that particular area, the equity, as you earlier mentioned. and proliferate through that equity, and those suppose religion, plays a lot of role in our country, in everywhere. So we had these different religious heads, Maulanas, coming forward and taking the vaccine shot. And it took a lot of persuasion, guarantees that I have taken a shot, so Maulana Sahib, you also take a shot. Or somebody who is stereotyped because of his topographical position. He's a tribal, he doesn't trust all this. We had mobile camps because we have a lot of nomadic population in J&K, which travels from one area to another. We had these mobile vans going on the road where these flock of sheep go from Pir Panchal range to the mountainous region of Kashmir in the summers, and then summers they come back. And we had, we had them taken across the roads when they were traveling, and we got them all vaccinated, even those who move, nomadic population. So I think, as I earlier told you, there are success stories in the society which you can create by doing so. It is all about the efforts you put into it.
Thank you so much, sir. And I would like to again take the same question to Dr. Leheria. What do you think local government-driven strategy that could be adopted to uptake vaccines? And I think one thing that I should mention, because I was reading your CV, it mentioned that you have done your research work on translating community-based health research into public policy. So if you can bring that perspective as well, that would really get.
Well, so of course, just to supplement what Dr. Khan said, that the answer itself is in the question. So when it's a local challenge, the solution will be locally designed by the people in that setting. Having said that, and I have studied during this pandemic what different settings are doing, as example, and there are many good examples. So one of the things is that state governments and district officials should learn from what other settings are doing. But two things which I want to highlight. One is that sometimes the way government communications are done, information, education, communication, are very mechanical. Like they simply hoardings and posters are put and it is assumed that people will change their behavior. But can we think of about ourselves that when was the last time when we changed our opinion because somebody told us to change our opinion? It doesn't work that way. So what is required that these communication strategies need to be more granular and locally adapted. The bare minimum any government or any setup can do, that information should be available in vernacular, the local language, and should be communicated by the local people. If a traditional approach of translating exactly, not the real meaning, but just literal translation of language is done, that will not work. So first thing need to be done, adapting those messages from the local language and communicating in their own way. Like people need to imbibe that message. I have an example of Melghat in Maharashtra, where rather than posters, they did skits and plays for tribal population. So that's one approach. Second is that influencers, elected representatives, religious leaders, all of them play very important role. We have an extensive learning from polio elimination program in India, that how religious leaders and other various influential groups were used to increase coverage. So those should be utilized. So these are the 2 points on local adaptation to address vaccine related challenges, but this is also applicable for other challenges, that we need to change our approach. We need to have a strategy in those settings, and this will come from local people. Once the state governments become open to the idea that solution can be local, which many of the state governments are there, and then empower those community, it works. The final point is, in my book also, I have always argued that from this pandemic, we learn one thing, which is a 3-way partnership. What is 3-way partnership? This is a partnership between elected leaders and policymakers, one group, technical experts and program managers, second group, and then community members, third group. So when policymakers, policymakers and senior elected representatives, program managers, health experts, and community work together, And when they identify solution, it always works better. It increases acceptability and it is more likely to succeed. And this is applicable for national level, state level, and district level, three-way partnership. And final part is that it cannot be ad hoc that we want to create partnership now. It had to be institutionalized. So what will be done here, and this can be started with COVID-19 pandemic, but this should be continued, and that's how we can improve health. So while challenge could be increasing vaccination coverage, the solution can be long lasting and can improve health services.
Thank you so much, sir. And your last point that you mentioned about the three-way partnership, I think is really interesting. And I really wish that we could have discussed this earlier because we are really short of time and I would really like to learn more about this three-way partnership itself. But as we are moving almost toward the end, I would like to just take one more question from the Q&A that we have received. What vaccination allocation strategies could be adopted to improve the current situation in India? So I would like to ask both the speakers who I would like to take this.
You want me? Okay, I can start and then maybe Dr. Khan can go. So I think soon there would be sufficient vaccines and then that challenge would not be there. But from now till there is a match between the supply and demand, and we should recognize the first thing in any program delivery that we recognize the challenges upfront and act accordingly. So currently there is less vaccine, more demand. So the available vaccine should be optimally utilized. For example, the vaccination has recently been opened for pregnant women. So I personally think the vaccination of pregnant women should be prioritized by all states because that's a high risk vulnerable group and we know to provide complete protection, especially in pregnant women, both shots need to be completed. So that should be prioritized by all state governments. Second, the state government should focus upon ensuring completed immunization of high risk population. Third, there should be attention on achieving saturation coverage for 45 plus population. And also some vaccination, if there is a balanced vaccine, then 18 to 44 years of age group, only high risk population should be given. We know the risk of severe disease, moderate to severe disease is higher in high risk population. So if 18 to 44 years are made to wait, it is not a big issue. We have whatever vaccine we have that need to be optimally utilized.
Dr. Shafqat Khan, if you would like to add something.
Yeah, I think I'll second what Dr. Chandrakant said, that we need to optimize the use of vaccines when it is in a stage where supply is less and demand is more. But eventually at this stage, I think the supply is very steady and we can hope that we will have enough number of vaccines for use on daily basis and the buffers, numbers we need to create so that we can have the vaccine in time. But there are now, apprehensions that if there is a third wave, we will need to have a third booster shot, for people to. I just went through this piece yesterday, and I think Dr. Guleria's piece, Dr. Chandrakant, who someone had said.
Yeah, so the third wave will be there. Many people are saying, yeah.
No, the third booster dose I'm talking about. The third booster you may require. I
have not read that, but it might be required, though a little late in India.
Yeah, so I mean, it's an evolving process. This disease has given a lot of people, lot of education, which we were not, in the early stages, we did not know. But nevertheless, I think the situation now is much better. We know how to tackle it, how to go about it. And as far as rationalization of the vaccine is concerned, I think the numbers are good. At least I'll talk about my UT of J&K, that the availability of vaccine is good and we have buffer stocks available and it is very steadily going. In fact, we may come up as a role model for vaccination in the country very soon, hopefully.
Thank you so much, sir. And with these, I have to unfortunately say that we are coming towards the very end of it. And I would like both the speakers for enlightening us with their perspective on the current situation of healthcare and vaccination policy. And there are multiple things that has come up from starting with the budget allocation issues to how it is impacting SDGs to what are the base challenges in terms of data collection, then how various sectors, for example, religious actors could actually play an important role towards the challenges of accessibility and affordability. And we also learned about some new projects, for example, three-way partnerships that we could actually adopt and the various strategies adopted in JNK and the specific challenges in JNK, as well as the different situation, for example, what is happening in India, but at the same time, we also received a very state-specific perspective of JNK, for example, how different districts are dealing with it. So with these words, I would like to pass on the mantle to Tanveer for the word of thanks. Tanveer.
Thank you, Jigyasa. And once again, a very good evening to one and all present here. I'm Tanveer, and I'm here to present the vote of thanks for today's session of the Expert Talk series. So it's such an honor for me to get the opportunity to thank you all, the dignitaries and the participants. On behalf of Jammu and Kashmir Policy Institute, I would like to extend a warm welcome to all the people present here and to the people who are connected with us and watching us live on different social media platforms. So I would like to express my gratitude and thank our guest speakers, Dr. Laharia and Dr. Shafkat, for taking time out of their busy schedule and enlightening us all with wisdom and knowledge. I would also like to thank and appreciate the organization team of the Jammu and Kashmir Policy Institute for working so hard and making this Expert Talk series a successful one. Thank you once again for being with us and making this a great success. Have a good evening, everyone.
Thank you, everyone. Thank you.